in people who are HIV infected or men having sex with men. The mother-to-child transmission is only 4 to 8% in case of your hepatitis C virus, and it is more when the mother is HIV positive. There can be inapparent transmission by sharing razors, toothbrushes, or close contacts. So how do we prevent hepatitis C virus? So the best way is screening of the blood and the blood products, injection safety, harm reduction interventions, safe sex, occupational safety, and no vaccine is yet available. So the best way is to test and to treat. Now, prevention of the nosocomial virus transmission, as had been mentioned in the previous slides. So the WHO has certain guidelines which states that we should follow complete hand hygiene, like proper surgical hand preparation, proper hand washing, and use of gloves. There should be safe handling and disposal of sharps and biomedical waste. There should be cleaning of equipments and screening of donated blood and improved access to safe blood. There should be proper training of the health personnel. So how do you prevent the hepatitis B and C virus in people who use injectable drug? We have to offer hepatitis B virus vaccination, and if needed, we can provide incentives also. And harm reduction, how can that be done? If the people is taking opioid, we should go for opioid substitution therapy to treat the opioid dependence, reduce the HCV risk behavior and transmission, and integrate the treatment of opioid dependence with other medical services. And prevention of sexual transmission is by proper and correct condom use, routine testing of the sex workers in high prevalence settings, integrated action to eliminate discrimination and gender violence, and increased access to medical and social services for vulnerable population. Now, in the May 2016, that has been mentioned by earlier speakers also, there was a global health sector strategy on viral hepatitis, and it had the vision of eliminating HIV, hepatitis B and C by the year to eliminate the viral hepatitis as a public health problem. And it focuses mainly on hepatitis B and C to increase the coverage of prevention and scaling up of the testing. So to sum up, I would like to say that hepatitis B and C is parentally transmitted. Hepatitis B in infancy or early childhood is particularly risky, and because a higher risk of chronic infection. And vaccination is an effective preventive measure for hepatitis B. Birth dose followed by 2 additional doses has 95% efficacy in preventing mother-to-child transmission, and anti-HBs titer of more than 10 by a milli international unit indicates adequate protection. So safe blood, safe injection practices, and safe sex are effective in preventing both hepatitis B and hepatitis C. So thank you all for being patient listener.
Thank you, ma'am. Thank you for sharing your knowledge and empowering her intellectually. And now we are moving to our next speaker. Now I call upon the next speaker, Dr. John Harvey. She is the Associate Professor in the Department of Community and Family Medicine, AIMS Yoga. She did her MBBS from Berhampur University and MD from NTR UHS University. And she has received 27 Dr. S. Radhakrishnan Memorial National Teacher Award and got Faculty Best Paper Award in the 16th State Joint Conference of IPHE and IAPSM. And she got gold medal in the International Salon of Inventions and New Technologies, New Time at Sevastopol, Russia. And she has received certificate, commendation certificate by Lieutenant Governor Admiral D.K. Joshi and ANN Islands on 11th in 2019. And she has published around 25 papers in various index journals and textbooks. And she has been principal investigator in various intramural and extramural research projects. And the topic she is going to talk on National Viral Hepatitis Control Program. Over to you, ma'am. Thank you.
Thank you, Dr. Sudha. Respected ED sir, respected Dean Research ma'am, Umesh Kapil sir, team ILBS. Today I'm going to talk about National Viral Hepatitis Control Program. So I just want to show the slide again to just give an emphasis that if we do not act right now, the hepatitis B and C virus infections are going to increase and it is going to be a major public health problem. So if we act right away, taking the baseline at 2015, if we have 30% reduction by 2020, the number of new cases would fall from 4.7 million to 3.3 million by 2020, and by 2030, around 470,000 cases. The same way with HCV, if we act right away with the program in place, then new cases would be reduced. And same with number of deaths. The number of deaths right now is around 884,000 for HBV and 400,000 for HCV. And by 2030, there will be a good reduction in cases if all of us act together for this program. So these are the targets set by WHO. The hepatitis B vaccination, taking the baseline at 2015 as 84% of infants were vaccinated with hepatitis B vaccine. Then the target we have to achieve by 2020 that we are supposed to vaccinate our children. 90% of the children should be vaccinated by 2020, and by 2030 also 90% of the children should be vaccinated. And prevention of mother to child transmission, this can be achieved by giving the hepatitis B vaccination less than 12 hours after birth. Right now, only 39% is the baseline. So we are supposed to achieve 50% by 2020 and 90% by 2030. And the blood safety percentage of donations screened with quality assurance by 2015. The baseline is 97% in 2015. By 2020, it should be achieved to 98%. And by 2030, the blood safety should be 100%. Injection safety, taking the baseline at 2015, 5% of the injections used in our country are unsafe. So we have to achieve a 0% by 2020 and maintain that by 2030 as well and forever. Hepatitis B virus diagnosis, baseline is 9% of infected persons receive a diagnosis. So we have to increase our diagnostic services and achieve at least 30% of the infected persons they should at least know that they have hepatitis B virus. And by 2030, 90% should know that they have hepatitis B virus. And hepatitis C, it is around 20% right now, 20% at baseline. And by 2020, 30 and 90%. Hepatitis B virus treatment, percentage of diagnosed who are treated are 8% at 2015, and we are supposed to achieve by 2030 at least 80%. And HCV treatment is 7% at 2015, and by 2030 we have to achieve 80%. So what is the gap? Why are we missing so many infections? So right now there are 257 million people living with hepatitis B virus, and many infected persons remain undiagnosed because they're not going to get diagnosed, or they do not know that they have the infection. So this gap we have to see and we have to achieve. So if you can see the slide of here, there is a lot of gap. So at least by 2030, 90% of the target we are supposed to achieve, that is all the infected should be diagnosed. So the same here with HCV infection. So there are major gap in diagnosis of HCV infection too. So by 2030, 90% of the infected people should be diagnosed and 80% diagnosed should be treated. So these are the hepatitis A, B, C, D, E. So as you can see, our country is hyperendemic for hepatitis A. 10 to 30% of acute hepatitis and 5 to 15% of acute liver failure are due to hepatitis A. And 40 million people are living with hepatitis B. The prevalence rate, as my previous speaker, Dr. Richa, has mentioned, it is around 3 to 4%. And there are 12 million people living with HCV. Prevalence is around 15%. And D, it is low, it is less than 5%. And E, again, it is high, which it is hyperendemic. And 10 to 40% of acute hepatitis and 15 to 45% of acute liver failure is because of hepatitis E. So at ILBS, there were 4 consecutive technical consultative meets were held. And before this program was put in place, all these meetings were held. And now we have got a national viral hepatitis control program in our country. It was launched in 2018. So these are all the books available online, and people are supposed to go through these books to know about all the guidelines. So the aim of National Viral Hepatitis Control Program are elimination of hepatitis C by 2030, reduction in the infected population, morbidity and mortality associated with hepatitis B and C, and reduce the risk, morbidity and mortality due to hepatitis A and E. So these are the objectives of the program. That is, it is to enhance community awareness on hepatitis and lay stress on preventive measures, provide early diagnosis and management of viral hepatitis at all levels of healthcare, primary, secondary, tertiary healthcare, develop standard diagnostic and treatment protocols for management of viral hepatitis and its complications, and develop linkages with the existing national health programs, and develop a web-based viral hepatitis information and management system to maintain a registry so that all this data will be recorded. So this is just the organizational structure, which is seen that at the national level, there is a national viral hepatitis management unit. At the state level, there is a state viral hepatitis management unit, and at the district level, district viral hepatitis management unit. And at all the levels, there are labs to diagnose, and even at the CHC and PHC and health and wellness center level, there should be diagnostics available. At least the rapid diagnostic tests should be available, and drug dispensation should be available at these places. So this is the overall framework where you have labs, and then state program management unit and national program management unit, where the national program management unit looks after the guidelines, policy making, monitoring, evaluation, surveillance, research. And there is a state program management unit where there are targets set and there is an intersectoral coordination. And at the labs, the diagnosis, treatment, referral, and quality control should be maintained. So these are the components. The preventive components are the main thing which has to be done is awareness generation and behavior change communication, immunization of hepatitis B. Birth dose is very important, as mentioned by my previous speaker, and the routine immunization also is very important, and safety of blood and blood products, safe socio-cultural practices, Safe drinking water, hygiene, and sanitary toilets should be provided. The diagnosis and treatment. The screening should be done on all the pregnant women in areas where institutional deliveries are less than 80% to ensure the referral for institutional delivery and for birth dose hepatitis B vaccination. Screening, diagnosis, and treatment are very important for hepatitis B and C, and it should be available at all levels, starting from the primary healthcare level, that is health and wellness center level, in a phased manner. And provision of linkages is very important, and there should be a linkage with the private sector too, so that the program will work even in the private sector. And engagement with the community, peer support, and ensure adherence to treatment. And all this is important for the program to go on successfully. So the diagnosis and treatment consists of screening. Screening can be done by rapid diagnostic tests. Confirmation can be done with the molecular test, and treatment of uncomplicated cases can be done at the treatment centers, and complicated cases can be done at the model treatment centers. And there should be always a linkage and referral put in place. So this is just a slide to show what are the tests available. There are rapid diagnostic tests, enzyme immunoassays, and molecular tests. So this is again a slide showing the various tests available at various sites. So the medical colleges, the tertiary centers where we are, here the model treatment center should be present, and treatment of hepatitis B, C and all the complicated cases should be referred here for treatment, and district levels at the secondary care level and sub-district at the primary care level. So here, this is the intersectoral coordination where all these should be in place so that the program will run properly. Swachh Bharat, MCH services, immunization, National AIDS Control Program, healthcare workers, injection safety, and surveillance. This is for all the hepatitis B virus. So the challenges that we may face are the linkage and continuity and the largest drop-offs and the treatment initiation, follow-up, and management of complicated cases. So these are the guidelines of the program. So this I would skip because my previous speakers had already spoke about it. So these are just the guidelines where the most important place where we can intervene is the mother to child transmission. Over here, if the birth hepatitis B is in place, then this mother to child transmission will cease to exist, and whatever is left, the other vaccine immunization can help, so that the cirrhosis won't occur in the child. So this is another flow chart for hepatitis B virus management. So if the hepatitis antigen is positive, and if it is negative, cirrhosis and non-cirrhosis, and depending on the parameters, the treatment options are available. So these are the drugs available which may be used. And this is like the algorithm where the new patients and the old patients, treatment naive is the new patients. If the patient is referred from other health center or healthcare policy or any other place, or suspicion of that he's having an infection, those are the new patients, and somebody who's referred is the old patient. So depending on the HBs antigen, the lab technician will draw the blood and do the test, and the treatment card will be issued to the patient, and the patient has to come for follow-up after 30 days. This is hepatitis C virus. Here, 20 to 30% of cases are acute and 70% of the cases are chronic. So this is again the management of hepatitis C. If there is confirmation of infection, it can be treated. So these are the category of patients where the regimen is mentioned here. So this is the treatment regimen available. So for almost all types of patients, 12 weeks is the treatment, and only in ribavirin intolerant patients, the treatment is around 24 weeks. So monitoring. After completion of antiviral treatment for HCV, there is no need for on-treatment lab monitoring, and genotyping is not recommended, only in some treatment combinations for drug resistance workup. So this is Hcv algorithm. It's almost the same. Here the patient has to return after 28 days for follow-up. So this is for hepatitis E virus. And this is for hepatitis A virus, the clinical illness, IgM and IgG antibodies. And this is the algorithm for all the viruses A, E, B, and C. So this is the treatment algorithm for diagnosis of viral hepatitis without jaundice, for hepatitis B and hepatitis C. So what we need to do is we have to find the cases, link them to care, and follow up and treat as per the guidelines. So the current status is 710 centers are functional in all the states and UTs. 75 lakh patients are screened for hepatitis B and C, and 71,000 patients have started treatment. So the smaller projects and state programs, and there should be a harmonization, and there should be introduction of hepatitis B testing for pregnant women and guidance on vaccination for healthcare workers at risk. So to summarize, in order to meet the 2030 targets, there should be a global reduction in hepatitis related mortality by 65% and new infections by 90%. The Government of India launched this program in 2018, and there is a need to enhance the diagnostics in viral hepatitis and increase the uptake of testing in the general population. So each state has to make the plan and put a proposal to the State Health Mission for coordination with National Health Mission for the program enrollment. Thank you so much. I'm going to change here.
Thank you, ma'am. It was very informative. Thank you once again. Now I request Dr. Namrata to display I pledge.
Thank you so much, Dr. Sudha, and I thank all the speakers for very wonderfully taking us through the sessions, Dr. Janvi, Dr. Richa, Dr. Suman, and in fact, Dr. Shyam Kishore, for elucidating the challenge that we are facing of viral hepatitis, and also making us aware very well with the transmission and prevention strategies, and very systematically taking us through the National Viral Hepatitis Control Program and the algorithms. Moving on forward, I request all the panelists who are joined with us today to kindly switch on your videos and unmute yourselves. I request all the panelists to please switch on your videos and unmute yourselves and repeat after me the I pledge oath. I pledge is an opportunity to mark a significant promise, not just to ourselves, but to the community, to stand in solidarity in our fight against hepatitis B and C. So I request you all to please raise your right hand and repeat after me. I pledge that I will try to keep my liver healthy. I pledge that I will get myself and my family tested and vaccinated.
I will get myself and my family tested and vaccinated.
I pledge that I will generate dialogue with my colleagues on hepatitis.
I pledge that I will generate dialogue with my colleagues on hepatitis.
I pledge that I will teach 10 people about hepatitis.
I pledge that I will teach
About hepatitis.
I pledge that I will not discriminate people living with hepatitis.
I pledge that I will not discriminate hepatitis.
Living with hepatitis.
I pledge that I will contribute in empowering people against hepatitis.
I pledge that I will contribute in empowering people.
Thank you all. Over to you, Dr. Sudha.
Just a minute, Dr. Namrata. We'll just be starting with the question answer session. Question answer for PowerPoint. Will you share them? So, a very good afternoon. It's my privilege to introduce, especially to our students, because all of us know about Sareen sir and Dr. Umesh Kapil. I'll be just briefly introducing them. Professor Shiv Kumar Sareen is the Senior Professor, Hepatology and Vice Chancellor, Institute of Liver and Biliary Sciences, New Delhi. He was instrumental in setting up the Institute of ILBS under the auspices of the Government of Delhi. He is also the Director, WHO Collaborative Center on Chronic Liver Disease and Viral Hepatitis at ILBS. He serves as an adjunct faculty, molecular medicine at JNU. I have the pleasure of introducing Dr. Umesh Kapil. Thank you. Respected Professor Umesh Kapil is an academician and an educationist par excellence. He has more than 4 decades of experience in research and teaching, and he has led numerous funded research and demonstration projects. He has published widely with more than 340 publications. He is actively involved in capacity building, designing strategies and policies for various state governments and the Government of India ministries of Health and Family Welfare, the Human Resource Development Industry, National Institute of Nutrition, ICMR, the Planning Commission, various universities, professional organizations, and international agencies like the UNICEF, WHO, and FAO. He has been the member of the National Task Force, ICMR, BIRAC, and DBT. So I request if Professor Sareen and Professor Kapil are there, they would join us as panelists for this question answer session.
For certain commitments and the OPD day today, unfortunately, we don't have Dr. Sareen joining us today, although we do have Dr. Manya Prasad joining us as one of the panelists. She is the Assistant Professor in Clinical Research Epidemiology, ILBS. Dr. Manya is very well published with 35 international and national articles in Medline Index journals. Her area of interest lie in epidemiology, medical research, systemic reviews, and meta-analysis, evidence-based medicine. She has also facilitated many workshops on research methodology, evidence-based medicine, and GRADE tool, and is instrumental in conducting these series of national webinars. She is the recipient of gold medal in her final exam, MD, and also the proud recipient of International Epidemiology Association Fellowship. I welcome you, Dr. Manya, and I also request all the speakers, the presenters for the sessions today to kindly address the questions.
Thank you, Dr. Namrata. Please share my screen. Question answers, PowerPoint. Q and answers. Next slide. So So again, welcome from AIMS Devgarh. This is a beautiful site of our campus. So we'll be addressing the questions one by one to our speakers and our distinguished faculties from ILBS. The first question, I would address this question to Dr. Shyam. How long does Dr. Suman or Dr. Shyam can address this question? How long does hepatitis B survive outside the human body?
It survives across 7 to 10 days outside the human body.
Okay, and it remains infective. Okay, next. Dr. Richa.
And the concept of hepatitis B virus vaccination at birth is to prevent the maternal to child transmission. As mentioned in slides of Dr. Janvi and me also, the National Health Program also emphasizes on birth dose so as to prevent the maternal to child transmission. So we prefer to give within 24 hours of birth the birth dose.
So there's another concept, just correct me if I'm wrong. They say that the earlier this hepatitis B vaccination is actually done, the lesser the chances of the chronic inflammation. So that also remains one of the important factors. Okay, next slide, please. Dr. Janvi, this is a very commonly asked question. Can hepatitis B and hepatitis C positive mother breastfeed her child? I mean, either Dr. Richa or you can address this.
Yes, ma'am, they can breastfeed the child because otherwise the other infections will be
The benefit outweighs the
Risk. And I think it's not really documented if breastfeeding transmits.
yes, ma'am.
Okay, next slide. Now, there's another query which is, mind of most of the healthcare workers, be it the doctors, be it the nursing staff, and for the infection control people who think about how they can protect their healthcare workers from this dreaded infection. So what is the role of hepatitis B vaccination for healthcare workers? Here, the question is not about the availability of the vaccine. It's more to do with the logistics of carrying out hepatitis B vaccination for healthcare workers, and especially like in institutes like AIMS, that is a teaching academic institutes, where students enter into the first year. Subsequently, they enter into the patient care where they are exposed to these kind of risks. So what do you think, how we should approach, like AIMS is just a new institute. So what, according to Professor, I would request Umesh Kapil sir to comment on this, that how we should move forward, what are the general recommendations for this vaccination for healthcare workers and students? Professor Kapil? Dr. Nurmita is there, sir is there with us?
Dr. Kapil is in another meeting, so maybe perhaps Dr. Manya can help us with this question.
Dr. Manya?
Yeah, sure. So, of course, healthcare workers all have to be vaccinated against HPV. And it's a very, very effective vaccine. So in terms of efficacy, we have a very effective vaccine for hepatitis B. For hepatitis C, of course, we have a cure now. But in terms of vaccination, all healthcare workers should get the regimen. So 016 is the regimen which should be administered to all health workers. And also in the time of COVID-19, there is some difficulty in maintaining those timelines. So a lot of people are experiencing missed doses and so on. So in such a situation, we don't need to restart the series. So if the second dose is missed, then the healthcare worker can just take it as soon as possible and then take the third dose 8 weeks later. And if only the third dose is missed, then that can be taken as soon as possible. So complete your vaccination series, even if COVID-19 precludes timely administration, still complete the series as soon as possible. And everybody must get vaccinated. It's a very effective vaccine. Over to you.
Yeah, thanks for that input. Next. Now, this is relevant to what Dr. Manya you just mentioned. So, could you probably continue on to this question? What to do if I miss the second dose of hepatitis B vaccination? Should I go in for the third dose? And when? Or should I start the
So there's
actually?
to restart the series. If you've missed only the second dose, then that can be taken as soon as possible. And then the third dose can be scheduled 8 weeks later. And if you have missed only the third dose, then that you can take as soon as possible. So there is no need to restart.
And there's another question, that people frequently ask in the staff that, Madam, hamara itte saal ho gaye, it's already 5 years, it's 10 years. Should I take a booster dose? So what is the current recommendation regarding the booster dose?
So, you can, in an ideal situation, you can check your serological response. So if you're concerned that, your antibodies may have gone down, you can get a titer done. If it's less than 10, then yes, you can go for a booster. In normal circumstances, in an immunocompetent person, there's generally no recommendation and there's no need to get a booster. I think 3 doses on a general basis maintains immunity for at least 30 or 40 years. So
Correct.
there is no requirement for a booster in general practice. If you are immunocompromised people are frequently non-responders. And if you feel you want to check your titer and it's less than 10, then yes, a booster is recommended.
Yeah. Okay. Next question. If a person is already infected with hepatitis B, can the person still be vulnerable to contracting HCV, or say a person with hepatitis C can acquire hepatitis B? Dr. Janvi, would you like to comment on that?
They are vulnerable. They are vulnerable to getting.
So the answer is simply yes, very much vulnerable. Either ways, the person is vulnerable. Next. Dr. Manya, this is a frequently asked thing. Will hepatitis B affect any other organ besides the liver adversely?
Well, hepatitis B directly, of course, invades the liver. So it causes chronic inflammation, fibrosis, cirrhosis, and hepatocellular carcinoma within the liver. However, resulting from that, it can actually affect a number of organs in the body. So yes, it can affect other organs in terms of complications. And of course, primarily, the infection itself is within the liver with extrahepatic complications.
Correct. Some of the manifestations, if I remember, there are some dermatological manifestations which can be seen, then some joint involvements. All these may be some common side effects or adverse effects of hepatitis B infection. So next slide, please. Now, this is a question which is asked. I am a hepatitis B positive male. Can I plan my family and have a healthy child protected from hepatitis B? Dr. Shyam? So usually what happens if a person is, we know that hepatitis B can be transmitted sexually. So a male can transmit it to the wife or the spouse.
So better way to vaccinate both parents, and they can plan.
They can plan, and the other thing is that there are certain modalities by which a newborn can be protected from hepatitis B, where I think you give passive immunization immediately, followed by a course of active. So yes, they can definitely plan. But the point is that they should definitely seek some medical advice. Some counseling is must before they carry out family planning. Next. So how soon after exposure to hepatitis B will symptoms appear, and what should be the post-exposure prophylaxis? Dr. Shyam has already mentioned earlier that hepatitis B is an example of a long incubation hepatitis, and it can take a couple of weeks to almost months for symptoms to appear. And post-exposure prophylaxis is definitely present in the form of the immunoglobulin doses. And remember that after passive immunization, the complete course of hepatitis B vaccination, active immunization should be followed up. Next. During the present COVID times, everyone is receiving the COVID-19 vaccines. Can hepatitis B vaccines be taken along with it? Dr. Mania, I think you did partially address this issue. Could you clarify this further?
Yes. There are almost no contraindications to HPV vaccine. It's a very, very safe vaccine. In fact, even pregnancy, newborn, everybody can get HPV vaccine. So yes, during COVID times, there is no contraindication.
Right. And if in case, like you mentioned, if anybody even misses a shot, they should just take the next shot as soon as possible. Next.
Yes.
This again, I think, address it to you, Dr. Manya. In spite of such an effective hepatitis B vaccine available for the last so many years, why do you think the decline in hepatitis B infection has not been more evident?
Well, if you look at the data, in fact, the prevalence of HPV in India is actually reducing. So while the current estimate from the WHO and of the paper by Schweitzer et al. In Lancet, as well as the CDA Polaris group, while they say that the current prevalence in India is just under 2%, if we compare this to 1950s, 1980s, then you will see that there has been a reduction in prevalence, and this can mainly be attributed to vaccination. So there are three main groups that provide the prevalence of HPV, and those are the ones that I mentioned. And they've systematically reviewed the literature on prevalence of HPV by measuring surface antigen, prevalence of surface antigen. And compared to the pre-vaccination era, there has been a reduction in prevalence is seen in India, and that is most likely attributed to vaccination.
Yeah, I agree to that, but I feel probably the vaccine now recently it has been introduced in the national immunization schedule as a compulsory vaccination. I think these steps by the government is actually helping us, step up our prevention of transmission of this infection. People should adhere more to it. From our own personal experience, we see these children who join the AIMS during the first MBBS prof. 2003, but still, what I'm trying to say is that it's quite a way time back, but that much of either issue must have been, though the government took a decision, but implementation takes a longer time, and adherence to what we suggest as healthcare workers. People are a bit skeptical, I've seen, about vaccines. So these might have added to why there is not a wider coverage, but I think now the situation has definitely improved. Next.
Yeah, so one of the main concerns with regard to vaccination being an effective intervention is that the coverage of birth dose of HPV is extremely poor still. So
Yes.
Less than 50% of districts in India have a coverage of over 70% of birth dose vaccination. So that is definitely one area that needs improvement. And as you very rightly pointed out in that very beautiful graph that was shown, the probability of chronicity it increases many fold by an earlier infection. So we need.
Yes.
Later on, if there's infection, maybe in adult life, the body is able to get rid of it. But early on in life, it can only be prevented by the birth dose, which still requires a lot of advocacy at our end. So that is one area that should be addressed very importantly.
So the bottom line of this question was that, yes, we should encourage this vaccination. It's an effective vaccine, one of the preventive vaccines for a cancer, which is well known. I mean, it can save so much of morbidity and mortality. Now, the next question is addressed to Dr. Suman. Would you like to comment on what is the survival of HCV outside the body? Can it survive?
Yes, across 3 weeks.
Okay. Next question. Now, this is a question which says that if I got infected with hepatitis C 10 years ago, which got cured with treatment, what are my chances of contracting it again? Dr. Manya, over to you on this.
Well, of course, yes, you can contract it again. Chances, I think, greatly depend on behavior patterns. I think it would depend on the exposure that you have to parenteral transmission in terms of IV drug use and blood transfusion and so on. So I think it's highly variable, but I think I would like the microbiologist also to get a rough estimate, if there's any rough estimate, population estimate of chances of reinfection.
So there are some literature available which show although there is very less chances, but it might occur in 1%.
So it is being reported, but not too much. So around 1%, you're saying.
Yes.
Yeah. Okay, next question. Prevalence of hepatitis C virus. We'll read many of these, articles in which they mention about this high risk group, the hemodialysis patients, and how the hepatitis C infection is, in at a higher percentage.
Yes.
Among this particular group, what as a microbiologist would Dr. Suman and Dr. Shyam have to say on this?
Actually, hepatitis C virus has a wider range of incubation period, maybe up to 6 months. So I think it may be the possible reason when hemodialysis patient having more prevalence of it.
And that what you're trying to say is that maybe at the time when the hemodialysis starts,
Yes.
or during the process, the initial part, though they may be infected, the tests
Yes,
are diagnostically, you can't pick them up.
Yes.
And actually, the lab diagnosis of hepatitis C can be very variable, and it has its own flaws.
Yes.
And due to repeated high risk exposure to this hemodialysis, they might get infected. But this is a very worrying kind of statistics which we get to read in the various articles being published. Next. Dr. Suman, what according to you, can you very simply explain that though we have such an effective vaccine against hepatitis B, why that effective vaccine is not yet available for the hepatitis C virus? What do you think is the major reason? What are the viral causes you think? What about the E2 antigen? Any peculiar behavior of the E2 antigen?
Actually, it is showing very variability, and it changes very frequently. So, one definite vaccine is not prepared.
So, what I think you're trying to say is that the antibodies which are produced against the E2 antigen of the hepatitis C virus are the protective antibodies, which might confer to some amount of protective immunity. Now, because the E2 by nature is a very variable kind of antigen which undergoes mutations. So, an effective vaccine, abhi prepare kiya aapne, malum pada antigenic change aa gaya E2 mein. Therefore, that vaccine becomes ineffective. So that remains the major roadblock in development of a effective hepatitis C vaccine. Next slide. This is something about the the National Viral Hepatitis Control Program. Dr. Janvi, in which year was this launched? And though you have mentioned your objectives in your presentation very nicely, do you think we have been able to actually achieve those targets, or what have been able to achieve till now?
It has been launched recently in 2018. So we have targets to achieve by 2030. So I believe that if all of us work together, then we will be successfully achieving the targets with the program in place, and with at all levels, if it works properly, we'll be able to achieve the targets by 2030. Here, the main problem here is on vaccination. So if we can increase the awareness of the people and the hospitals where the vaccination is being given, that it should be compulsory for all institutional deliveries and for all the deliveries outside home also, that they should be brought to the health center within 12 hours for the vaccination of hepatitis B. So it is an achievable target if we all work together.
Yeah, so this kind of webinars which we are holding, and ILBS is motivating all these institutes to hold these kind of webinars through the telepathy initiative. I think this goes a long way in creating awareness and stimulate people, and so that they can also inform other people, as we took the pledge just now. Next slide. So, okay, Dr. Manya, could you please address this question? What benefits are being provided by the government under this program at the state level, the district level, and the individuals in terms of, diagnostic support, treatment support? Just a brief about what the government is doing, just briefly.
So I think this was beautifully covered in the presentation of Dr. Janvi.
I think I could hear it once from you, so
Yes.
that people understand it
So,
once more.
So this program was very recently launched in 2018, and right after the drafting of the operational guidelines and getting the stakeholders together, COVID hit. So in terms of implementation at ground level, getting the blocks together again, because COVID severely interrupted those efforts at the community level. But what is envisaged under this program is that rapid diagnostic kits and regimens for treatment of HCV will be provided at all districts, and this will be provided free of cost. So diagnosis, treatment free of cost to all patients, screening, health education, vaccination, of course, is already being done in the immunization program. So public health measures in terms of all of those best buy efforts that go towards elimination by 2030 are being envisaged under this program. In terms of implementation, after this roadblock of COVID-19 is overcome and the interruption of services, this will gain momentum again.
Right. Okay, next slide. So this is an open question which we all can address, including Dr. Manya. What do you think we can, move forward for AIIMS Devgarh in this program? I mean, how do we envisage ourselves? I can add to this. I can see myself as at least we can start the training and awareness programs. We can, with like we have done with ILBS. Similarly, we can support the state. We have enough resources in terms of faculty who have been previous trainers from the earlier institutes where they were. So that is how I see it as a beginning, phase 1, as they say. Dr. Manya, what do you foresee for us? How you can encourage?
What I foresee as a center of excellence, nothing else and nothing less than that. I think as is the case with all centers of excellence for any program, it's going to have a multifaceted role. So of course, training is going to be one thing, but we also expect state-of-the-art research from institutes like AIIMS Devgarh. We envisage training of trainers, of course. We envisage, fierce advocacy for public health interventions, and just an apex institute with regard to forwarding all of those elimination efforts. So state-of-the-art center for excellence in the future is what I envisage.
Correct. And like you were talking about the research, that's what I said, that we should now have scope for some collaborative research in viral hepatitis at AIIMS Devgarh, and we can do so. I mean, you can provide us with some hand-holding for our budding young scientists here at AIIMS Devgarh. We got a nice group of young faculty, I think, who are very enthusiastic, and I wish them all the best as the Dean Research here. And thank you, Dr. Manya, for joining us.
Thank you so much. My heartfelt gratitude to AIIMS Devgarh and to all of the speakers for so successfully conducting this webinar in collaboration with ILBS. We are so grateful for all the efforts, and I'm sure that the iterations made today will go a long way in strengthening the government's efforts towards hepatitis elimination. So thank you once again, and thank you so much.
Over to Dr. Namrata.
Thank you so much, Dr. Pratima and the faculty from AIIMS Devgarh and Dr. Manya joining us from ILBS for very skillfully and very exhaustively addressing the queries and making sure that all the aspects are covered of the queries, and beautifully conducted, Dr. Pratima. Thank you so much for that. So I request all the participants to now please go through the post-webinar survey, which is being displayed on your screen right now. And for any queries, you may please feel free to reach out to us at webinarilbs@gmail.com. We would love to hear your suggestions in case how you would want us to improve on these webinars or any assistance that we could be of. Dr. Pratima, we can have the concluding remarks now.
Yeah, that's what I was going to say, that before we start, I could just propose a vote of thanks. So I deem it a great honor and privilege to propose a vote of thanks on this occasion of the webinar being jointly conducted by AIIMS Deoghar and ILBS. So when eating a fruit, always thank the person who planted the tree. First of all, before I thank everyone else, I'm very thankful to our executive director, a great leader and a thinker of our time, Professor Saurav Varshney. Sir, your gracious presence in today's function has been a source of guidance and inspiration for us. And in anticipation for the days to come for AIIMS Deoghar, thank you from all of us. We convey our sincere thanks to the distinguished guests present here with us, who motivated us. Dr. Sareen, Dr. Kapil for guiding and motivating us to conduct this webinar. The entire team of ILBS and the empathy team, especially Dr. Rahul, Dr. Namrata, with whom I have interacted personally and found them very focused and clear in their instructions to us. Great work. So thank you all for the support and direction to conduct this webinar. We are delighted to have the speakers, Dr. Janvi, Dr. Suman, Dr. Shyam, Dr. Richa with us. I thank them for their unstinting support and gracious presence here today. The successful culmination of this program is due to the guidance and support of our IT team, especially Dr. Urmila Sinha, Mr. Ajay, Mr. Mahendra, who helped maintain the link with our participants, ILBS, and our panelists. A special thanks to Dr. Anita, Senior Resident Microbiology Department, Dr. Sudha, Senior Resident Pharmacology Department at AIIMS Deoghar for holding the loose ends together. Last but not the least, I would like to thank the faculty, staff, and students of AIIMS Deoghar for their overwhelming participation and support, thus making this program a resounding success. I thank you all for this. So thank you. Now, Dr. Namrata.
Thank you so much once again, Dr. Yes. Thank you once again for all the audiences, for your patient listening as well. I do hope and believe that you most certainly must have gained much more deeper insights into the challenge of viral hepatitis and the prevention and control strategies to follow. Thank you so much for joining us today. I request all the audiences, participants to kindly click on the link that is being posted in the chat box. Conversely, you can scan the QR code that is being displayed on your screens right now to fill the post-webinar link. Please be patient with us as the certificates might take about 3 days time to get delivered to you. So make sure that you do fill in the post-webinar link with your contact details, including the email IDs for us to correspond with you. Thank you so much for joining us today.
And please ensure that you all fill in this post-webinar assessment, because that is how you will be receiving your certificates subsequently. Dr. Namrata.
Yes, I'm here.
Showing pre-webinar link. Could you just check this?
This is the post-webinar link that has been shown on the screen.
That's okay. Yeah. Dr. Pratima.
So the webinar links, dear all, the webinar links would be on open for another few more minutes. Please ensure that you click on the link posted in the chat box. Fill in your details, answer the questions, and be patient with us while the e-certificates are sent to you over your email. I hope you all have been able to click on the link and submit the responses. The webinar link will be open for a few more minutes while our team is signing off. So thank you so much for joining today. Please do get connected with us at theempathycampaign.com. We do have an exhaustive knowledge repository on the website, theempathy.com, and I'm sure that this webinar has been a step in the right direction, and we shall be collaborating in further endeavors. Thank you.